So my name is Nicole Lamana. I'm a CLL specialist at Columbia University Medical Center in New York. And I have the pleasure of having Dr. Clare Sun from the NIH discuss one of her presentations, one of the abstracts that got presented at the annual hematology meeting, the ASH meeting in December of 2022. Thank you, Dr. Sun, for being with me. And she's going to talk about the longitudinal mutation profiling in CLL patients during acalabrutinib therapy and at progression. Dr. Sun, you want to tell us a little bit about the design of this study that you did and what the implications are for patients?
Happy to. Thank you, Dr. Lamana. So the abstract that we presented at ASH this year was a follow-up of a study that we previously reported. This was a phase 2 study of single-agent acalabrutinib in patients who either had relapsed CLL or treatment-naive CLL, but with high-risk features, specifically with deletion 17p, TP53 mutation, or Notch1 mutation. And this study randomized 48 patients to receive either acalabrutinib 100 milligrams twice a day or 200 milligrams once a day, which is not the approved dose. We reported the results previously that found the twice daily dosing seemed to be more potent in terms of suppressing B-cell receptor and downstream signaling in CLL cells compared to once a day. And this abstract is now focusing, with long-term follow-up patients who are now progressing. So we have about 5.5 years of follow-up now. And over these 5.5 years, 17 of the 48 patients, so about a third of the patients, have developed progressive disease, mostly CLL, but also a few with Richter's transformation that occurred mostly early on study. So at 5 years, the estimated progression-free survival, meaning the proportion of patients who remained in remission essentially and on treatment, was 62%. So that's a very good number considering the high-risk features of our patient population. And then the median progression-free survival was estimated at 6 years. So I think that's good news for our patients with single-agent Acala, that durable responses can be achieved, even in the presence of TP53 aberrations or Notch1 mutations. And then we wanted to focus on the 14 CLL patients who progressed. We know that BTK and PLC gamma 2 mutations are now widely recognized as resistance mechanisms to ibrutinib, and then maybe to a lesser extent acalabrutinib as well, although less data exists for acalabrutinib. But there still remains a minority of patients where these mutations and these genes are not detected. So when we started this study, we prospectively collected tumor samples at annual intervals on our patients, and then we banked them for a possible analysis later, which is what we ended up doing. So we analyzed 212 samples and for next generation sequencing, and specifically looking at genes that have been reported as possible drivers of CLL by others. And patients had a baseline sample, a 6-month sample, a 12-month sample, and then so forth until 5 years on study. Or if they reached progressive disease, we collected a sample at that time as well. So whatever occurred earlier. And looking at the genes that were mutated, we found that there were 25 CLL driver genes that were mutated across 47 of the 48 patients. So nearly all patients had at least one driver gene that was mutated at baseline. And then we followed the frequency of these mutations over time. And interestingly, what we found was there were 2 genes in particular, BCOR and FPEN. These were recognized CLL driver genes that were exclusively found only in patients who subsequently developed progressive disease. And it also looks like over time, the frequency of these mutations increased until the point of progression. So perhaps suggesting they had some sort of survival advantage enriching for these clones. We also, of course, looked at BTK and PLC gamma 2, which are the common culprits. And we found in this study that 70% of patients had mutations in either gene that could explain the disease resistance to acalabrutinib, but there was still 30% who did not. And so through this longitudinal profiling, we were able to identify 3 genes in particular that were acquired during treatment in the absence of either a BTK or PLC gamma 2 gene. And those 3 genes were ZNF292, which is the recently described driver mutation, Notch1, as well as BRC3. And those are previously been described as drivers in CLL. So while this isn't conclusive in terms of, identifying genes that lead to resistance to acalabrutinib, I think, we're adding more samples as we speak to try to understand, whether these genes are more recurrently enriched in these samples that don't have a BTK or PLC gamma 2 mutations. We're looking at pretty small numbers here. And ultimately, if we think that these could potentially be genes that explain resistance, we'll need to do more mechanistic studies to confirm.
This is excellent. I mean, obviously, I think for patients, one of the things that you said in the beginning that was very important is this was either relapse refractory patients or patients who had high-risk features to their disease, and yet the median follow-up was 5.4, right? 5 years of data, which is incredible. So these folks are doing better with the BTK inhibitors, in this case, acalabrutinib. So I think, first of all, that's wonderful news for our patients. And then second of all, you were looking at the patients who were on this therapy, what might be the mechanisms that are driving their progressive disease, albeit at that time point, it was only about 1/3 of patients that progressed. So that's wonderful news for these patients. But if we can learn more about these mutations that develop, then of course, this is something that hopefully will be followed more commonly, maybe in the future, as this becomes more doing this more in real time in practice. Then we can see if patients are developing these mutations, that we know that they might develop progressive disease at some point in time. And then the question is, how maybe we can use this for future therapies, right? So this is excellent work. Clearly, we're going to need more of this and longer follow-up in patients with CLL. And I know that you guys are doing follow-up studies on the patients with these longitudinal samples, which is excellent. So we need this kind of correlative work from our patients and on the studies that we are all conducting. So Dr. Sun, I want to thank you so much for doing this work and for speaking to our patients about your work. And hopefully you'll continue to contribute more in the future.
Thank you very much for having me.
Thank you.